yes or no answer?
Not a yes or no. So a yes or no question is, do you have pain? Does it hurt? Okay, you're kind of limiting their options if you ask a closed-ended question. Tell me what happened. Describe the pain. And the reason why we're teaching you to do that is because when you do your assessment for the CAT exam, you will get lots of information by asking an open-ended question. You will get 5 ticks with 1 question. How many ticks do you get if I ask Jeff, does it hurt? He says yes or no. How many ticks did I get for that? Just 1. Tell me about your pain. And he can go on and on and on and on. When I asked Matthew about his patient the other day, Matthew just blah, 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 and I just sat there listening. Yes, more checks.
How do you get some of the kids to answer that? 'Cause one of them I asked what it felt like, and he's just like, So then I had to explain, perfect, feel this, this, and this. So I gave him the answer.
That'll happen. So what we'll tell you is start with open-ended questions. Your patients are going to vary a lot, especially with STS. So Neil works with little kids right now. When he comes over to do the other sites, he's going to work with college athletes who will be able to give you a description. Give examples is one way. At some point, you're going to have to ask closed-ended questions at some point. But you'll get more information right off the bat with open-ended questions. Based on what you're thinking with your indices, if there's some information you need to rule out some of those indices, ask a direct question. Okay? And that is okay. There's nothing. You can ask closed-ended questions, but it's easier if you start with open-ended questions. Tell me about your pain. Tell me about any medical conditions that you might have. And then more likely not, they'll say, like what? Then you can start asking, okay, well, do you have diabetes? Do you have this? Do you have? But then other people might say, well, I had surgery, I got diabetes, and all you did was ask one question. Okay. It's a better strategy to ask an open-ended question first, and then ask direct questions after. And again, if you're working with kids like Neil's working with kids, you might have to paraphrase. I did a SCAT. It was something similar to the Paralympics or Special Olympics in Florida. It was like a community thing. And as part of the concussion testing tool back then, it was one of the cognitive tests was say the days of the week backwards. The kid was about 13, but he was a special needs kid. And so I sat there and I was going through the form like I was taught, and their teacher came over and said, I wouldn't be able to do that anyway. So for those of you who've done concussion testing before, you need to recognize what their baseline is. And that's why it's important to know your athletes. There might be some people on your teams, even varsity athletes, that might have learning challenges. And some of the traditional questions you ask for other people, you may not be able to ask for them. Know your patients. And so you might have to learn how to do this. Okay, we'll give you a template, but it's just a template. It'll become your own eventually. And it might change depending on the person you're working with. Okay, so patient information. So I don't like starting off with this. I usually leave this towards the end. But that's me. Someone's seeing you for a reason, and they really want to tell you why. I normally do the introductions, and I say, well, tell me why you're here. Why did you come see me? Describe what happened, describe your pain, describe your discomfort, describe your activities. How is it limiting you? Like, how is it affecting the way you play? Just tell me about it. And then based on their answers, I would ask direct questions. And at some point, I'll ask these other ones, because you might find some other things about this stuff that might help you put a better rehab plan together. Okay? For example, occupation sport, you probably know what their sports are because you guys work with their teams, but occupation might play a role in how fast they get better. For example, what if someone's a server in a restaurant and they have a bad ankle sprain? And you put together the best rehab plan ever. And they're going through the rehab plan every single day, following everything that you tell them to do, paying attention to everything you say in the clinic when they do the rehab. And then they go to work for 5-6 hours on their feet. They come back and their ankle's this big. And you could have sworn you did the best job in the clinic. Well, why is their ankle that big? So is this information going to adjust your rehab plan? It will. You might have to try to compromise with the person, be like, I know you're struck up for cash, but is there anything else you can do at your job to protect your injury? Prioritize. What is more important to you? Playing in this next game, or playing in this tournament, playing at the CIS championship, or 2 extra shifts? And again, that's something that's off the injury now. That's something they have to prioritize themselves. But they make the decision, not you. You just tell them what's up. And if they say, you know what, I can't even afford school, I need to work, then your rehab is strictly going to be manage the swelling so that that person can work. Secondary, soccer. Okay? But you need to ask that question at some point. Okay, but that's an example of how something non-traditional could potentially affect your rehab plan. How old the person is, activities of daily living, that's pretty common, that acronym. Smoking is for more degenerative conditions. Stressors in their life is a good question because that will determine how compliant they are as well. If they're not compliant, you can tell them anything you want to do. They're not going to do it. They spend 30 minutes to an hour with you in the clinic. What makes the biggest difference is what they do on their own. It's just like class. I can give you a good 2-hour lecture, but it's what you do with that lecture outside of here that will make the difference in how you progress academically. Same thing with the rehab. If you tell someone to go home and ice 3 times before they go to bed, 20 minutes on, keep it elevated, with compression afterwards, put that horseshoe on the way I showed you, and they don't do it, it's not going to make that big of a difference. Now, if they do, and they come back the next day and the swelling's completely gone, how does that make you feel? If they're compliant. But if there's a lot of this going on, it might be hard for them. So if you find it out, at least you can give them some options. Talk to your coach, talk to a nutritionist, talk to a sport psych person, whatever. But at least you know, and you can start giving directions. And last but not least, dominant, that could be implicated in your rehab school. Again, typically I would leave this towards the end. Previous injuries, actually that one you might want to ask right away, especially if it's pertinent to the site of injury. Motor vehicle accidents, serious hospitalizations, family history, medications, and menstruation, pregnancy. Medications that you're taking now or recently, or did you take any today? That is important. Why? What type of medication? Inflammatories or? It'll affect your assessment. Not muscle relaxants.
Pain pills.
Pain pills. Why? What are you trying to do during your assessment? Sounds terrible, but what are you trying to do? You're trying to recreate the pain. But if they take painkillers, analgesics, then your special test that you're expecting to be positive with pain will not be painful, and it'll throw you off. So if they did take a couple Advils right before they came to see you, just take their history and say, listen, come back another time, come back tomorrow, but do not take your Advils again. I mean, you can try some special tests, but if it's not eliciting certain things that you're expecting, then it's probably the medication. So that's important. Why is surgeries and hospitalizations important? We'll talk about chronic injuries. We talked about it earlier with symptoms that present in different areas than where the pathology is. So if they had an appendectomy, they had their appendix removed, could that cause shoulder pain? Absolutely. Okay, so if this has happened, you definitely need to follow up with this, especially if there's potential that the visceral stuff could be referring pain to the periphery. Okay. There is a picture in McGee. It's a fantastic picture. I use it as well, but it has all the organs and arrows to where the pain refers to. Okay. So someone was in a motor vehicle accident. They had, their chest at the steering wheel. They had some surgery on their liver, but they're presenting with chronic shoulder pain. Is it rotator cuff, or is it a complication of the surgery? You could be doing rehab on their shoulder for months and months and months, and it's not getting better. Maybe it was a complication with their liver. So So it's important to ask that question as well. Okay, so these next two slides, I like to start with. That's just me. You can start the other way if you like. But this is the information you must get when you're doing a clinical assessment. When you're doing a field assessment, you'll recognize that some of these may not be that pertinent, like this. Not really pertinent on the field. Does it hurt when you sleep? No, I just heard it, you idiot. So you don't need to ask that question. But generally, these are the questions you need to ask. Chief complaint, why are you here? And it's not always pain. They might even say, I'm having trouble going down the stairs. They might start off with that. Why? It hurts and it buckles. And then start playing detective. Date of injury, why is that pertinent? Acute versus chronic. Your acute assessment might be a little bit different than your chronic. You might be looking for certain things if it's acute. Mainly sharp. Anybody know what sharp is? Swelling. Altered function, fantastic redness, and pain. So date of injury. If it's acute, you're more likely to see this stuff. If it's chronic, you won't. Okay? So you need to know exactly when they heard it. And it could be, I'm not sure. It started, I think, a few months ago, but it progressively got worse. If they say that, is it acute or is it chronic? Probably chronic. Mechanism of the injury is very, very important. Because that will give you a lot of information to what structure is actually damaged. If they can't remember what the mechanism is because it was a little twinge a while ago and it just got worse and worse and worse, then it's chronic, but at least you know it's chronic. There was no mechanism. So chief complaint, date of injury, mechanism of injury, sounds, and sensations. What does a pop mean? Let's start with the easy one. What does a crack mean? Snap. Probably a fracture too. Well, I guess I can go either way. So tendon, something ruptured, something broke. That's a snap, usually. Pop, dislocation, or muscle tendon rupture, or ligament rupture, so ruptures in general. Crunch. Crunch. Typically two spots where they might complain about that. Crunch, 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 crunch. Cartilage, take your ear and go. Crunch. Where else is there cartilage in your joints? Like this type of cartilage in your joints. I can think of 3 off the top of my head. Yeah, there's nose. Where else? Ribs, yeah. Where else? Well, I didn't think of those. Those are good. I was thinking 3 different spots. Fibrocartilage. Your knees. Okay, that's your meniscus. Fibrocartilage is your meniscus. Shoulder, there's your labrum. And there's your triangular fibrocartilage complex in your wrist. Okay, they're all the same material. Those are areas where you might find it, or they might complain, I twisted and I heard a crunch. They probably ripped the meniscus a little bit before in the labrum. Okay. So those are different sounds that people might say that they heard. Do you have a question, Jeff?
Fractures, you don't move them.
I would say it depends. Upper body, I would try to move them. I tried to move a 6'8" guy who had his arm was stuck like this, but he went pale, so we had to lie him down right away. That's a funny story. I was an AT student in New York. I was working in Mills, and he was stuck like this. And I was like, "What do you mean you can't put it down?" I grabbed his arm and I went. It was like this, but it didn't hurt. It was just stuck. Don't do that, by the way. It looks kind of silly when you're pulling on a dislocated arm and stuff like this. So we actually had to lie him down. He was going shocking. But the stretcher we had was meant for a 5'10" guy. So his legs are dangling over the ends and his arms like way out. And we couldn't get him through the door because his arm's so long. It was hectic. And his buddy had a hatchback. So he couldn't even lay down in the back, so his legs were hanging out the window too. It was terrible. Anyway, yeah. Moral of the story, that's not how you put a dislocation back in. Hang off his arm. Anyhow, Sound sensations, very important. Sensations, it's not just numbing and tingling, but what are the sensations might people complain about? And those of you who had knee injuries or ankle injuries, you might complain about this as well. Or those of you who have dislocated your shoulder before might have felt this as well. What other sensations?
Burning.
Burning, instability. These are just adjectives we're coming up with. But these are types of words you can use as examples for your patient. Because they may not know what you're talking about either. Does it feel unstable?
Crepitus.
Crepitus, good, that's weird. And clicking might be weird too.
Pressure.
Sorry?
Pressure.
Pressure, good. Swelling, that could be an indication of swelling. Tightness, burning, coldness. What does coldness indicate? Circulatory issue, possibly. Anybody ever have a knee injury where they're like, oh, and then you can't help it, but it does that? It is the weirdest feeling. It makes me puke. I've had it once and I don't like it. But that feeling of instability or giving way, that your knee's not even there, is just weird. But those are some sensations. But take some of those adjectives that people mention and put that on your list. If someone doesn't know what you're talking about, then you need to give them some examples to help them along. Shard, swelling, heat, altered function, redness is not pain, because we're going to ask pain questions later. What's D? And this goes under observations, by the way. That's what you're looking for under observations. What do you think D would be? Discoloration and or? We were talking about fractures earlier. Deformity is good. Okay, swelling, heat, altered function, redness, discoloration, deformity. So these are the sensation things. So you can say numbing, tingling, burning, nerve type of feelings, or instability, clicking, walking, as well. Function, how is it affecting your function? That's a fantastic question, because that's what they're concerned about. Damn it, I can't reach on the shelf anymore. I can't scratch my back, so I have to rub against the wall. How is it affecting your function? Is a fantastic question, because that's what you have to get them back to. If it's activities of daily function or daily living, or if it's sport function, sport specific, position specific even. Okay? If a basketball guard cannot dribble, you've taken away their bread and butter. Different for a big guy. Big guys don't have to dribble. They can just run, catch the ball, and okay? So you need to find out what they're limited to and what their priorities are. Physios get people back to doing this, typically. And then they send them off and you're good. But we're different. We have to get them back to sprinting, running, jumping, humping, cutting, throwing, pulling, doing all sorts of high performance type stuff. And doing this isn't good enough for a high performance athlete. That's our bread and butter. So you need to find out what type of function is limited. Okay? That's why it's important to ask about their sport. And when it said sports on the previous page, it's not just what you play, position, how often do you play, when is the next competition that you're aiming for, what type of sport utilities do you use? Do you use a stick? There's some sports I don't even know. So if you're not familiar with it, either YouTube it and watch, or do some research on it, or even ask them. Show me the types of things that you want to be able to do again with your good side. And last but not least, sleep. If it's painful or discomfort or uncomfortable when they're sleeping, it's a bigger problem. Okay. And so that's an important question, especially if from all this, it sounds like it's chronic, it hasn't gone away. If it hurts when you're sleeping, now we're thinking something a little bit more of a red flag. Okay. Pain, PQRST, I think some of you might have seen that before. PQRST is just a way to remember the types of pain questions in there. Where's the pain, when's the pain, how much, describe the pain, is it getting better, is it getting worse? When you do this particular function, because remember last time we talked about function, what hurts and what doesn't hurt, if they say it hurts to go up and down the stairs, you need to ask them more specifically using these questions with respect to that particular movement. So when you said it hurts to go up and down the stairs, which one hurts worse, up or down? Give me a number when you go up and down stairs. Is that number different compared to when you walk? Is that number different compared to when you play your sport? Because it might be, and that might help you refine your rehab program a little bit better. This one, like Neil was saying, that might be a little bit challenging for people that don't understand what you're talking about. So describe the pain. And again, adjectives. So the typical ones are sharp and dull. Some other adjectives for pain that people might come up with. And there's no right or wrong. It's just that's how people describe it. Other words people use, you think? Describe pain. Shooting? Good. Throbbing. Radiating. Sore. People say sore. But what's sore? Is that dull or is that sharp? Who really knows? You just have to ask more questions, right? What other words do you think people would use?
Stabbing.
Sorry?
Like stabbing.
Stabbing. That's a good one. I've heard that before. Someone said pressure or tightness. Is it pain? Burning? I can't remember. There's a website that had at least like 40 different adjectives. Usually you'll become comfortable with about 4 or 5, to be honest. But just realize that there's 40 or 50 out there that you might come across in different situations. The question is, are you thinking the same thing they're thinking? So if you're not sure, just ask more questions. It also helps to give them examples. Like if I take this sharp little object and I poke it, does it feel like that? If I take your, and I squeeze, is that what you're feeling in your knee also? So there's some ways, and I just do that because I've worked at a camp with kids for about 5 or 6 years. And so we've had to modify a lot of their questions, especially when they're like 8 to 9 years old. So PTRC, palliative or provocative, what makes it worse? What provokes your pain? Palliative is just the word they use for, I guess, symptoms, like how did the pain begin? Quality of the pain is usually described, so the quality, sharp, dull, so on. Radiating or referring pain, does it go up or down your limb? Severity, that's your number, 0 to 10. And T, when did it start? That's your date of injury, essentially. For severity, just a quick little side note on severity. When you tell someone, some of you might have done this before, 10 is the most pain you've ever had in your life. 0 is no pain at all. What some people do is they'll provide examples. For example, like 10 is like getting hit by a bus. Has that person ever been hit by a bus before is my question. So how are they able to compare it if they haven't been? It's like being shot. Depends where you live in the city, I guess, right? So a simple generic way to say it is the most pain you've ever experienced, whatever that might be, how do you compare that to this now? Is it really debilitating like that other pain? If that pain was debilitating. Some people may not have been injured before. First time ankle sprain is always the worst. So your pain scale, 0 is no pain, 10 is the most pain you've ever felt in your life. But when you say stuff like getting hit by a truck, people don't understand that usually. Safety. So this is one of those other ones based on previous injuries. So if you've been hurt before, did you actually see a physician or other healthcare professional for this particular injury or for other injuries? Because that information might give you some information as well. Yeah, I've seen this person for this. It didn't help what they did. Well, what did you do? They told me to do these exercises and these exercises. I'm a water polo player. Did it help? Nope. Still can't do the ball. Well, did they ever get you throwing stuff? Nope. Well, I think I can help you with that then. Okay. So that information is important. Diagnostics, obviously, if it's something more traumatic, fracture, cartilage, ligament issue, if they had an MRI before, that can help confirm your suspicions. And last, again, we talked about medication. Are you on medication? Have you taken any for this? Okay, so this is important to note because if any of this happens or you find any of this stuff, it's a little bit more, I don't like using the word severe, but it is something to be more concerned about if you have any of these red flags. Any questions about anything on that list? I forget what the stage is. Matthew, can you look at dysphagia? Can you Google that? Diplopia? Any ideas? Double vision. Sorry, I should have asked. Anyone know what dysphagia is?
Isn't it like trouble speaking?
I'm not sure. Matthew will be on top of that. Go. We'll stop on that for a second. Dizziness, vertigo, drop attacks or fainting. That's terrible. That's potentially a cardiac condition. And fainting, in accordance with other symptoms, might suggest
inability to speak or understand words.
Fantastic. Yeah. So slurred speech, I guess is a simple way to say it. So slurred speech, double vision, unexplained weight gain or weight loss. What is that indicative of potentially? Diabetes, thyroid issues, cancers, HIV, AIDS. There's so many different things that can be the result of. Loss of coordination, head injuries, potentially something central nervous system related. History of cancer, it could be related to these other things. You can ask that question of, do you have any medical conditions? Tell me about your medical conditions. Yeah. Unhealing sores or wounds, MRSA. Oh, sorry, do you guys know what MRSA is? MRSA. Methicillin resistant Staphylococcus aureus. You have that on yourself already. It's just different strains that are terrible, that eat away flesh, and there's no antibiotic to fight it. So they call those superbugs, I guess you could say. A friend of mine's dad almost lost his leg from snorkeling. He just grazed coral, had a little scab, and next it just grew and grew and grew, and it wouldn't stop. Put the polysporin on it, cleaned it as much as possible, but he had to be hospitalized. And he ended up being in the hospital for about 4 weeks, and they were this close to amputating his leg. But MRSA is pretty nasty. So those of you who work wrestling, there's ringworm you have to be aware of, but also be aware of that, because that is contagious as well. Trouble initiating urination or control of bowels, that's usually lumbar spine or sacral problems. Numbness in the saddle area, same thing. Those of you who decide to work rodeo, Mark and Bonnie actually did a fantastic case review on someone who had a peduncle nerve compression that was ongoing for years and years and years, and that person went through the whole list of practitioners and finally got treated by Bonnie and Mark at the same time, and his symptoms are down to maybe 5% and staying that way, because there's times he got treated by other people, got better for the day, but it came back. So that rider was actually pretty thankful that it was finally solved. But his issue was dizziness. That can be embarrassing for people too. Okay, so again, when you history taking your assessment, patient comfort is very important, especially when you ask questions like this. Numbness and tingling in both hands and feet at the same time. What does that suggest? How do you know what burners and stingers are? Okay, so burner, stinger, shoulder, brachial plexus compression of the nerves. What's the difference between nerve sensation down one side versus nerve sensation or symptoms down both? Again, you're comparing, contrasting injuries now. Someone comes up to you like, I've got numbing and tingling, and you ask where, and they say just in this hand. Is that a huge problem? But if they say, I've got numbing and tingling in both hands, is that a huge problem? They walked. What is tingling in both hands? Let's say it's football. Yeah. C-spine. But they're walking. It happens. A good friend of mine went to school with, we both worked through football back in the day. She got a job with the Argos. And she worked with the Argos for such a long time. And she actually said they had a 2-week walking spinal. Yeah. Dislocated vertebra. Walking. Doing stuff. Neck was just tight. Anatomical anomaly. Nobody caught. When they finally did the MRI or the CT, they took a coronal section of her vertebra, saw that the one vertebra shifted about a centimeter, which is pretty big. But if you guys know what the vertebral canal is, what is it?
The vertebrae.
Yep. What goes
And
through
the
it?
spinal cord goes through.
Vertebral canal is where the spinal cord goes through. It was huge. Put your finger in my vertebral canal. It shifted, but it never touched. That's why he was able to walk and do stuff. That wasn't even the surprising part of the story. I'll tell you that in a second.
Was there numbness and tingling in both arms?
There was, but it went away. He still had neck pain, so they got him doing exercises and stuff. Which, now that you think about it, bad idea. But guess what they recommended to fix it? How would you fix that? What's one option? I heard someone say it. What's one option to fix that? You go in and fix it. Surgery, right? That's one way. They suggested putting it back in.